If a doctor recommends you to cut a nerve, that's not a good doctor.
I was recommended by a female physician that I just cut my pudendal nerve. And I was like, that seems a little extreme. And she was like, well, you need to be able to satisfy your partner. And I was like, I need to leave. I'm in danger. This is not a safe place. You can cut a nerve and the pain will persist, but all you did was ensure that they would also never have pleasure. And that I think is really problematic.
Dr. Anna Sierra
is transforming the field of pelvic health as a world-class endometriosis surgeon and neuropelviology specialist.
A trailblazer in her field, she's a published author and part of the team behind the first neuropelviology paper out of Mexico. At the renowned Doyen Institute in Mexico City, Dr. Sierra uses cutting-edge techniques to help patients overcome endometriosis, vascular compressions, pelvic floor dysfunction, and more. Get ready to meet the woman redefining pelvic healthcare.
We talked about clitoral orgasm.
Yes.
Everybody accepts that. But the G-spot, that one is super controversial. There are people who are like, absolutely not. There's no such thing as a G-spot. Tell us what's the truth there.
There's an anatomical spot there. You can even feel it. There's like a change into the muscular and the vaginal layers. It's more like...
Welcome to the Dr. Brighten Show, where we burn the BS in women's health to the ground. I'm your host, Dr. Jolene Brighten, and if you've ever been dismissed, told your symptoms are normal or just in your head, or been told just to deal with it, this show is for you. And if while listening to this, you decide you like this kind of content, I invite you to head over to drbrighten.com, where you'll find free guides, twice weekly podcast releases, and a ton of resources to support you on your journey. Let's dive in. Okay, so we're going to get into a topic that many women have a lot of questions about, but they feel sometimes too ashamed, or they get judged and treated poorly by their doctor when they bring it up. So for everyone listening, if you have kids in the car or you're listening with children right now, go ahead and turn this episode off and listen to it another time. Because we're going to talk about pain with sex. And this is not going to be like raunchy or racy or anything, but we are going to get into the anatomical details. You even brought a model about what is going on. So when we talk about pain with sex, as doctors, we really flesh it out. It's more than just pain with sex. Let's talk about the definition and the difference between if it's happening at the entrance or if it's happening deeper within.
First, the medical word that you're going to hear is dyspareunia. Mm-hmm. And there are like 3 words that need to be defined. One is dyspareunia, that is pain during sex. The other will be vulvodynia, that you're going to hear also. And the last one would be vaginismus. If you go to the doctor, they're going to prescribe something in between them, but you really need to know the difference between them. If you have pain during your intercourse, that's dyspareunia. If you have pain with or without intercourse in the entrance of your vagina, that will be the vulva. The vulva will be the outside part. The inside part, it's the vagina, because some of our lady friends do not know the difference between them. And lastly, the vaginismus. This is a term that most doctors use like too much. And it's a reaction that some of our patients have of their pelvic floor, and it contracturates all of the muscles, and it can cause pain during sex, but it's not the same thing as dyspareunia. Mm-hmm. So that will be the clinical part of it.
Yeah. Well, I appreciate you providing those definitions. I wanted to start and like say the words, but I was like, no, I want you to be able to like take us through that. So I think it's important for women to understand. So dyspareunia is pain with sex, but when we talk about vulvodynia or vaginismus, that pain can present not necessarily during sex.
Yes, of course. And also we have to define where does it hurts. Mm-hmm. The first thing that you need to do in order to advocate for yourself, if you're going to a consult with your regular GYN, first, you have to map it. You have to find it. Where does it hurt? Mm-hmm. If it's on the entrance, if it's in the middle part of the penetration, or if it's in between or in deep penetration, because the causes of each one of these sites is different. So in order for us doctors to understand your pain and to try to find the causes, we really need to know where does it hurt.
So vaginismus versus vulvodynia. How can women determine the difference?
They don't have to determine the difference. I would advise them to really understand where does it pain. Where is the pain? I will provide you one of the drawings that we have in order to understand the terminal branches of the nerves that goes into the perineum. There's like a border nerve syndrome there. There are a lot of nerves that collide in this area. So after you find the pain, we need to map it. And we have to get a cotton swab test in order for us to understand where does it hurt. So when you go to the consult, we have to examine you, and we're going to get a cotton swab, and we're going to trace lines in all of your perineum, in your vulva, everywhere, so we can understand where does it hurts, if the pain goes outside. Then when we can find it, then we can try to fix it and we can try to treat it. But that will be for the outer side of the vulva, well, on the perineum. It can be all the way around. So you can collide. You have genitofemoral nerve, you have pudendal nerve, you have obturator's nerve, you have the femoral cutaneous nerve. You have a lot of nerves that go into this part of your body, and you need to understand the difference between them and the difference between the types of pain, because some of the pains do get better when they flex themselves, like when they contract this part, because the psoas muscle gets into those nerves. And when you go like this, the pressure is lower. And then you have other nerves that go, when they stretch themselves, the pain increases. So there are little difference between each of these nerves. And some of these nerves, for example, the pudendal nerve, you have a lot of other symptoms like genitourinary symptoms, or even like trying or pain trying to poop, or the sensation that there's like a foreign body in their anus, sometimes with problems with the pudendal nerve. So in order for us to understand all of these nerves, we have to understand every difference that these nerves have. And this is only about the outer side of the vulva. When we're talking about the middle part and you have deep or pain during penetration, the middle part would be the muscle layer. So if you have pain there, maybe that's the vaginismus part. Vaginismus is when you're not even letting anything go in because of the contracturations of the contractures of the muscles. The muscles are so tight. And the thing is that some of our patients do need physical therapy, and some of them do not believe in physical therapy. And some of them find physical therapists that do not understand the pain. And they tell them, no, you have to go and do Kegels. And Kegels are the best thing that you have to do. And what I try to explain to my patients is when you go to a trauma surgeon because you are contracturated and you have like the very much pain in your shoulder, you have a contracturated shoulder, he doesn't tell you, okay, you have to go to the gym and strengthen that muscle. Because you even get worse. So it's the same thing in the pelvis. If you have a contracturated pelvis, you don't go and do Kegels in order to strengthen your pelvic floor. You need to understand how to relax and how to contract the muscle voluntarily. So that's the thing.
Well, it's so interesting that you say that, because I think all of us understand, like when you're doing a bicep curl, you're going to contract and you're going to relax. And so it feels like this is something I should just know. But when it comes to the pelvic floor, what we find is that most women do not know how to relax. Most women are contracting, and that can be contributing to pain. And I don't hear physical therapists say as much, just do Kegels, as much as I hear gynecologists just say, just do Kegels. I think physical therapists at this point are just like, everybody just calm down about the Kegels, because they're a good idea when done correctly. But most of the time, there's this focus on contract, and there's never this pause and relax. And when we think about the pelvic floor, I mean, it's holding up a lot, right? I want to go back. So the vaginismus, you were talking about the vulvodynia, we were talking about the cotton swab test. How often are these kinds of exams being done for women? Because when women present with pain with sex, they don't necessarily get referrals to physical therapists. Someone might be listening to this right now and be like, cotton swab, no one ever checked this out. How common is this?
You need to go to somebody that understands pelvic pain. That'll be my key point, and to go to reference. You have to understand that not all of the doctors are formed or do have this knowledge. And in order to get a proper physical exam, you have to go to pain or pelvic pain specialist.
So with this mapping that you're doing, this can tell you the specific nerves that are involved with vulvodynia. What can then be done about that?
It depends on the cause because not all of the nerves are like entrapped.
Okay.
Sometimes we can have like surgeries or previous surgeries that can get into the way of the nerves. Especially, for example, with the genitofemoral nerve. They used to get like one of the techniques for a cesarean section is that they strengthen this part of the pelvic, this part of their belly.
Yeah.
And there goes the genitofemoral nerve. So when they strengthen it too much, or sometimes in laparoscopic surgeries, when they do not know where the nerves are or where do they get outside of the pelvis, they can injure this nerve. And the pain can appear up to 10 years after the surgery.
Wow.
So it's really hard for the doctor to understand the pain that has been established after 10 years of a surgery, and now the patient has pain. And there are two branches of the genitofemoral nerve. There's the genital branch that goes into the labia majora, and there's the anterior of the femoral part. So if you get injured in the main branch, you're going to have feelings or alteration in the sensation in both parts. But if you get only into the genital part of the genitofemoral nerve, you're going to have like a numbing sensation on the labia majora.
Yeah.
And sometimes they get mixed up with the pudendal nerve, because if a patient has pain in their perineum area, well, they refer to me always as the pudendal nerve. There's like, no, that's a pudendal neuralgia. And I was like, no, not everything is about the pudendal nerve.
Yeah. But it does get reduced to the pudendal nerve a lot. I think I had shared with you in my 20s, I had vulvodynia and vaginismus. Two very common things when women are on birth control pills that I found in the research. And I was like, so 10 years of me having this pain and being on the pill, and nobody thought to say, maybe this could be a pill side effect. But I was recommended by a female physician that I just cut my pudendal nerve. Just cut it. That's what I should do. And I was like, that seems a little extreme. And she was like, well, you need to be able to satisfy your partner. And I was like, this lady should not practice medicine. I was like, and this is like, I'm saying this as a patient that I was like, I need to leave. I'm in danger. This is not a safe place.
If a doctor recommends you to cut a nerve, that's not a good doctor.
Yeah.
There's no release of pain by cutting a nerve. If we cut your hand, you're going to still feel your hand because there's the phantom syndromes. So you're going to still feel the pain. And now we cannot do anything in order to treat it. So even if it's a pudendal nerve, there's no way, there's no reason to cut it. The pudendal nerve, it's a sensory and also a motor nerve. So you can have problems trying to pee, trying to poop, trying to get like sexually aroused. There are a lot of things about the pudendal nerve, and there's not only sensorial things. There are a lot of more motor things. So if you cut your pudendal nerve, you may not be able to empty your bladder. So no, never cut the nerve.
Yeah, rolling with catheters for life. No, thank you. And as you bring this up and you say you can cut a nerve and the pain will persist, but all you did was ensure that they would also never have pleasure. And that, I think, is really problematic, because then, it's really easy when our body is showing signs of what medicine would term dysfunction, or we perceive as dysfunction, to feel like we hate that part of our body. That part of the body is like betraying us. And I think that's a really dangerous thing to be doing in women's medicine. Now, we were talking about the causes of vulvodynia. Surgery came up. So C-section, laparoscopy. So you perform a lot of laparoscopy because you're an endometriosis excision specialist. How can someone listening to this right now with endometriosis ensure that their surgeon is going to know where those nerves are before they get in there, or going to be looking out for them? Is there anything that can be done?
Yes, they have to know where the iliohypogastric and ilioinguinal nerves are when they are entering their trocars. And you can see them because you can ask them as small as this, like, do you care about the nerves when you enter with your trocar? And that's the only thing that you have to ask.
You really have to ask a doctor, do you care about the nerves? Yes or no,
because,
sir?
Some of the GYN surgeons did not get into their formation about the nerves in the pelvic wall.
Okay.
And they do know that they are there, but they try to avoid them. So you have to physically see them with the camera. It's better in order to avoid them. No?
Okay.
So there are little techniques that you can improve in order to guarantee that these nerves are or won't get injured.
Outside of surgery, what else can be the root cause of vulvodynia?
Well, there are a lot.
You're like, buckle up.
Okay, yes.
Buckle up.
No, but, okay. So also pelvic congestive syndromes, if they are compressing key nerves. But in pelvic congestion syndromes, for example, we can see even patients that have problems with the collagen, like, for example, ladies that do have Ehlers-Danlos syndrome, because those ladies do have their blood vessels can move.
Yeah.
And if those vessels can move, they can kink and they start growing, especially venous. So when there's an enlarged venous system, you can have a compression in the nerve. And it's only not because the cause it's in the nerve, but there's something else that is compressing the nerve. So yes, adherences can also be caused by this. So vulvodynia can be caused by a disease that we are really familiar with, that it's endometriosis. And the pain in these cases, it's more deep. So when we're talking about dyspareunia that goes into deep penetration, we have to think about the adherences that do come with endometriosis, that they get stuck into the rectum. So sometimes one of my patients tell me that when they get penetration, they feel that they want to poop.
Yeah.
So those are all of those nerves getting
Which
together.
is super distracting. Let's honor that. When women are like, I can't stay in the mood, I'm having inability to orgasm. Yeah, if you feel like you are going to poop every time you're having sex, like, you're going to be worried about that.
Yes. And it's not like a really good feeling. And also the pain, because they are entering a space that is really tight, and they get together with all of these things. And there are a lot of terminal nerve branches there. So you have to respect that part and to understand really the causes that can go with it.
And for people listening, so the vagina is supposed to be like an accordion that can expand. I mean, in common day, it's, these 8-pound bowling ball human heads. I just laugh because I've had two vaginal births. But I think sometimes, like, when you think about adhesions, as you're saying with like endometriosis, I think about, like, if you know what an accordion's like, what if you stapled certain areas of the accordion and then you're trying to stretch it, right? It's getting stuck. And then you're wanting to be careful because you don't want it to damage. And not to say that you're a musical instrument to be played, but I think about that of like, there's supposed to be this expansion, and yet we can have those constrictions that are there. You brought up connective tissue disorder. So it's interesting because I had messaged you. And I can't remember, I was asking you something about like ADHD women and I think pelvic pain syndrome. And I took a deeper dive and I found research that showed that women with ADHD and autism are more likely to be diagnosed with endometriosis. And if you have endometriosis, you're more likely to be diagnosed with one of those conditions. And what we also see with those conditions is connective tissue diseases and hypermobility. And so it's interesting that you're bringing that up about, and for everyone listening, pelvic congestion syndrome, we talked about in our first episode together. So I'll link to that. So you were saying with the blood vessels, but I would also think if there's hypermobility within the hip joints, surrounding the pelvis itself, because I thought, you have a model here, but we don't have the whole pelvis that you've got, like, I just think of the song, like thigh bone connects to the hip bone, like, and then you've got your spine, like you've got all of these connections, but there's instability there. I would imagine that could be a contributing factor as well.
Yes, everything goes into it. And also about your accordion and the vagina, I think it was really amazing. But also think about the vagina, and in the outside of part of the vaginal accordion, you do have all of the pelvic floor muscles. So those can also contribute to the pain. So you have the vaginal layer, and the connective tissue layer, and we have also the muscle layer. So there are a lot of things that can contribute to pain.
Yeah. And I have to, I was sharing with you before we got started. So, and my audience knows, so my posterior fornix, which is the terminal end of the vagina, was had adhesions up to my bowels. Like, oh Lord, like I look back to it, all these things of like, I had vulvodynia, I had painful periods, I had vaginismus, like all of this stuff. And I'm like, the signs of endometriosis were always there. The fact that not a single doctor ever thought of that is wild to me. This was before I was a doctor having all of these problems. But, as I was sharing with you that after my excision surgery, that's when I started to experience pain with sex. And it's not because anything went wrong with the surgery. You were there. You can attest to it.
Yeah.
But it is that things shift and they change, but there's also been a lot of trigger points. And I feel like after the surgery, I've been working with physical therapist, Diana, that both of us know, and the layers that we've been able to go through that I'm sure that was like that time that I fell, on the bars. People can see me on YouTube straddling bars, fell straight down like when I was like 12. Like I'm pretty sure climbing the ladder on the playground. And as I think about all of this, I think a lot of women don't recognize that once you have a trauma in the pelvic floor, if you don't address it, those things can linger and they can last.
Yes, of course. Everything counts for it, and your body remembers. Also, in patients with endometriosis, what you have to think about is that for so many time, they have been trying to protect themselves from the pain. So they start contracting their pelvic floor muscles. So they try to protect themselves. So they do not know the difference between wanting to pee and having pain, wanting to poop and having pain, trying to relax their pelvic floor muscles. It's a training. So all of our patients need physical therapy in order to reconnect with their pelvic floor.
Yeah.
It's really important because some of the times that we have patients that have micturial reflex alterations, it is not really about the wanting to pee or not being able to empty their bladder. It's about the pelvic floor muscle doesn't relaxing and doesn't giving the correct signal into their brain. So it's really important when you have the diagnosis of endometriosis that you reconnect your brain with your pelvic floor and you start feeling your body again.
Yeah. Oh, it's been, I think, 8 months now since my excision surgery, and people are like, "You're still going to physical therapy?" And I'm like, oh my gosh, I thought I had worked with physical therapists in the past. I thought I could relax my pelvic floor. It was not until after excision surgery that I really came to recognize there's a whole layer of relaxing my pelvic floor that I wasn't doing. But once my pelvis was no longer inflamed, it didn't have all these adhesions pulling everything everywhere, like the muscles could start to shift and change. And it takes time to rehabilitate a pelvis. I mean, I'm in my 40s. Like I've had endometriosis for about 30 years of menstruating. It's not a surprise that, I'm having to take so much time to rehabilitate the pelvis. So with vulvodynia, so we talked about endometriosis, we've talked about connective tissue disorders, we've talked about surgery, pelvic congestion syndrome, anything else women should be aware of that can contribute to this? Because I think what the point you're getting at is that we have to understand the cause. And if we understand the cause, then we can come in with the right treatment.
Yes, I think understanding first, where is their pain? Second, to get a proper exam. Sometimes when they go into their doctor's office, if you have pain on the outside, they will probably, when they tell you that you have something stinging in your vagina, they will tell you, oh, that's a yeast infection. Or there is some form of infection. Hopefully you'll get an exam. Sometimes they didn't even get an exam and they get their ovules prescribed and that's it, right? And sometimes when they do a speculum, they don't see anything because pain is not something that you can see in the flesh or in somebody's body, right? If you can say, this is painful, but I cannot see it. You have to trust in the patient. So I think it's hard. And then sometimes they do underestimate the amount of terminal branches that are on the vagina and on the cervix. I think that's something that our colleague doctors need to understand, like the amount of terminal nerves that we do have there. And for example, if in my patients that do go or need to go through a hysterectomy, the first thing or the only thing that they do tell me, it's like, what about with my body afterwards, right? If I'm keeping my ovaries, I will keep my hormones. If it's the same thing, well, there are studies that if you get through a hysterectomy, you won't ovulate as much and maybe your menopause will come sooner. But also the thing that most of my patients do complain about, the ones that did enjoy them before, are the cervical orgasms.
Yeah.
Because those stop. And nobody told them that they weren't going to be able to have a cervical orgasm. So if they have adhesions or any problem with deep penetration and they do not enjoy deep penetration, it's okay. And they are even relieved by it. But those who did enjoy before the surgery do miss it afterwards.
And this is after a hysterectomy.
After a hysterectomy, yes.
You just said that there are a lot of terminal nerves in the cervix. In the United States, gynecologists have argued since I have been around that there are absolutely no nerves in the cervix. There's no reason to offer any pain management for IUD placement. And it wasn't until 2025. And also, it wasn't until enough women were given social media platforms to speak up about it that doctors could no longer ignore it, that finally a position was made that, like, we should probably offer some pain management for an IUD placement. You're a pelvic pain specialist. What are your thoughts on that?
There's like I don't know, like an unknown fact that women that do have like a paralysis because they have a spinal cord injury can still have orgasms, cervical orgasms. Why? Because it's mediated by the vagus nerve. When we pull really tight into the, like, for example, the uterus, when we are performing, like doing like a pap smear or when you're inserting an IUD, the patient can have a vagal response, right?
Yeah.
So the vagal nerve is responsible for the cervix. So that's the answer. So you don't have to argue. Do you know about the vagus nerve? You can ask the doctors if they're telling you that you don't have any terminal nerve branches. You can tell them, how about the vagus nerve? You have a lot of terminal branches. So the vagus nerve transmits the information from the cervix. It bypasses the spinal cord and goes directly into the brainstem. There's like the nucleus of the solitary tract where all of the information for the orgasm integrate, among with other things. But especially in patients with spinal cord injury, they can still feel orgasms thanks to vagus nerve. That it's only on the cervix. So yes, it's really important to know all of this.
Hold up. We got to talk about this, okay? Because think about, just from an evolutionary perspective, like, why would this be the case? The vagus nerve runs from the brain. It innervates the gut and the heart and the cervix. What was Mama Nature doing? Just speculate with me. What was Mama Nature doing with that?
I don't know. It's like a straight line, and you can see all of the connections of the vagus nerve, and it has been think about like to be the treatment for pelvic floor muscles or not pelvic floor muscles, but for chronic pelvic pain.
Yeah.
Yeah, specifically, it has been like one of the things that maybe we can modulate in order for our patients to feel less pain. It's still on a very early stage in order for us to see that the vagus nerve stimulation is the way to go and is going to cure so many patients about their pain. But we do know that there's a lot of nerves that we don't know and that they are innervating this.
Well, and when you think about vagal tone, so vagal tone is associated with more heart rate variability, and that is associated with better health outcomes, more resiliency to stress. We are always trying to get people to stimulate their vagus nerve. So gargling, humming, singing, massaging. There's even like devices that can vibrate with your vagus nerve. And this is a way that can really help you manage your anxiety. It gives a sense that you're safe. And so it makes me wonder, what is Mama Nature doing putting a vagus nerve in your cervix? It's receiving information about safety, which is something that I have framed a lot to patients, is that when we talk about pain with sex, like relationship issues come into this because one, it can affect your relationship, but two, if your partner isn't making you feel safe, how can you have that level of vulnerability? People think, oh, vulnerability, like you're being intimate. No, someone is physically inside your body. Like when we're talking about vaginal penetration, like that's incredibly vulnerable. I feel like it's one of the things like driving in cars, we just take it for granted because it's just like, that's what people do. And yet, like driving in a car is also like this really dangerous, vulnerable thing. Like we're flying down the highway. I don't know in kilometers in the US, like, it's like 65 miles an hour in this metal thing. And we don't stand back and think about like, there's so many things in our life where we just kind of take it for granted. And yet our biological self is still scanning for, am I safe or am I not in these environments?
Yes, of course. I think, about the orgasms, that there are a lot of nerves that go into it, right? We have, of course, the pudendal nerve, but there's also a sympathetic and parasympathetic phase of it. So we do have the hypogastric nerve and the inferior hypogastric plexus, that it's like the uterovaginal plexus, and the vagal nerve. So we do have these 4 groups of nerve that do contribute in order to get this response, first the spinal cord, and then into the brainstem, and then into your cerebral cortex, in order to have all these hormones releasing of oxytocin, dopamine, prolactin, noradrenaline. We have all of this mixed up. So I think there's a lot more in orgasms than just the things that sometimes get described.
Yeah. In my book, Is This Normal? When I was advocating for pain management for IUDs, I had found that, the vagus nerve is one of the nerves that innervates the cervix. But something I didn't think about then, but I'm only thinking now in this conversation, is that we talk about how good orgasms are for our health. And there's all these reasons, but I also wonder, like, is it helping with that vagal tone? And it's very possible.
Yes,
like, we need research on this. Now I got so many questions. I need some studies.
It can be relaxing. So definitely, yes.
Yeah. I think this is really interesting. Let's talk about the physiology and the nerves and what is going on with an orgasm. Because I think, the research is actually really boring when you ask people, like, what's an orgasm? And everybody's like, it's a buildup of pressure and a release. And it doesn't matter what gender, they all like say the same thing. And I'm like, that's the human experience of it. It sounds really dull. It's much more dull than what it is. Let's talk about what is actually going on physiologically. Because this is a conversation we've never had on this podcast.
Okay. Well, we have the excitatory phase that it's mediated by the parasympathetic system. So you're going to have this release first, and then you're going to have a plateau mediated by the sympathetic system. And then all of this integration of systems are going to get into your brainstem and your cerebral cortex, and they're going to have the release of hormones.
I love that.
So you have dopamine, you do have prolactin, you do have oxytocin, and you have noradrenaline. So after this, we have we have the descent of everything, and that will be mostly, yes.
Yeah, we have the descent of everything, but what's really cool is that leads into the refractory period, which women have like this much of a refractory period, and men have like this much of a refractory period.
That's the only thing about the women that is a good thing. Like, right? Multiple orgasms are like the only thing good about being a woman.
Oh no, there's so many good things about being a woman.
Those are the only one that men cannot like. Sometimes men can go like, but I won't like to be the one who's able to charge a baby or carry the baby. And if you go to men and you tell them, yeah, but I can have multiple orgasms, they go like, yes.
Oh, it's funny. Everybody was reading these books, these Sarah J. Maas books that have fae. Have you read them?
Yes.
Oh, okay. Like Akatar. I don't know if you had the same thought, but these men, they have an orgasm and then they're ready to go again and go again. And I'm like, what is happening with the fae that the refractory period is so short? And the whole time I'm like, people are like, oh, you're really into these spicy books. And I'm like, I usually fall asleep during the spicy scenes. I'm really dull like that. But I'm also like, what is happening with the refractory period? And like, how is the, like, physiologically, like, what is different?
I read the books and I've never thought about that. So now you give me something to think about.
Reread them. I think the 6 books coming out or something, reread them, everybody, through that lens. People can let me know in the comments, like, what do you think is physiologically going on that they have shortened their refractory period? So in terms of nerves, okay, so the gold standard of achieving an orgasm for women is the clitoris. We know this from the research. Is the predominant way that women will orgasm. But there are women who report vaginal orgasms without clitoral stimulation, although it's hard to know, right? Because the clitoris is like this giant, like
body.
it's like half an octopus in there, right? There's only four branches. Yeah. Just hanging in there. So it's like, well, maybe it is being stimulated. But you mentioned cervical orgasm. Can you talk to us about the different ways that women are able to achieve an orgasm and how that relates to their nerves?
Yes, of course. For example, patients that went through a hysterectomy that no longer have cervical orgasms, they still have clitoral orgasms. They'll still have their G-spot, and they'll still have their vaginal walls. So through all of this, they can still achieve an orgasm. So, but the thing is that they refer to it as different if they have pleasure before.
Okay.
Sometimes they hate it, then they don't like it. So they are even relieved by don't having any cervix anymore. So they are happier. But sometimes they do miss it. So it depends on the women.
If you ever get your cervix smacked really hard, that I'm like, I always think like men are like, oh, you women have no idea what it's like to be like kicked in the balls. And I'm like, okay, have a gynecologist hit your cervix with a speculum or close the speculum on your cervix, and that is far, far worse, I would contend.
Or maybe have a condition like endometriosis, when you have your ovules stuck into the backside of your uterus. That will be like having your testicles stapled to your leg.
Yeah.
So maybe that'll be
yeah. I think people right now are probably, their eyebrows are like in their hairline, like, what? So we talked about, the clitoral orgasm. Yes. Everybody accepts that. Cervical orgasm, I think, I actually wrote an article about this like 8 years ago for Mind Body Green, and people were like, you're crazy. This is not a thing. I'm like, patients tell me it's a thing. But the G-spot, that one is super controversial. There are people who are like, absolutely not. There's no such thing as a G-spot. It was just some man trying to name a part after himself. Tell us, because you're the nerve specialist all up in the pelvis. What's the truth there?
There's an anatomical spot there, and you can even feel it, that there's like a change into the muscular and the vaginal layers. It's more like hard, like rugose. How do you say it in English?
Yeah, it's more like your nose.
Yes.
Yeah,
like,
not
like wrinkled. I would say like it has different texture.
The rugae is what you're saying.
Yes, thank you. Yeah. So if you did stimulate this, they can achieve orgasms quicker sometimes and with more intensity sometimes. And it also can help if you can get a little bit of pressure up to the tip of the uterus, so you can get everything like more together and you're gonna feel more feels.
So pressure on top of the abdomen pushing the uterus down is going to basically make that G-spot present.
Yes.
It's going to be more prominent. Yeah.
You're gonna have more space and
Yeah, well, it's just really interesting because it's mostly gynecologists that I see that say that will refute the G-spot. But what's interesting is that these same gynecologists will also admit that they had absolutely no education in like pleasure and sexual health. Like it was very, very minimal. It's just basically like, pain with sex, yes or no? Can you have a baby, right? Like it's really reductionistic a lot of times in women's health.
And it's really hard when I see men talking about female orgasms. I was like, yeah, you cannot feel it. So I'm sorry, but I don't know. I was seeing an interview yesterday of a really old doctor that says that endometriosis can get cured through hysterectomies. And I was like, dude, no. And another doctor was like, yes, trying to explain the way that women feel pain.
Yeah.
And I was like, there's no way that you can understand or that you can explain me this, because I cannot even understand it because I'm not feeling it. So I think sometimes, I don't know, I don't like the way that they do try to explain it or understand it or gaslight our patients. Like, oh.
Yeah. You know, to your point about men co-opting women's health, I think that is really the problem, is that they center themselves as experts. And what they do in doing that is that they decenter women's voices, women's experiences, and they disempower women by saying like, I'm a man, I'm an expert on your body. I know more than you do about your body. And in reality, we are unique. We all have we basically get like this same roadmap of a makeup, but there can be variations, but our experiences within our body are what are absolutely so unique. So I absolutely agree with that. I cringe when I see men online, and there's just been this really big phenomenon lately too online where a lot of men are wanting to step in and be experts over women's bodies. I find it so bizarre. That's not to say they can't have expertise, right? There's male gynecologists. They're brilliant. You know, Ram Cabrera, who we've had on the podcast, a mutual friend of ours, you don't hear him talk about endometriosis from like, this is the way it is. He talks about it from, this is what women tell me. This is what women say they experience. And I think that little bit of a nuance makes all the difference. And it's very telling. I think, I always joke that I want to run through doctors' offices, like throwing red flags, like when they do and say things. If you have a doctor who is talking down to you, or asserting that they have an expertise that like means that your experience is invalid, that's a red flag. And to me, it's a red flag when I see men talking about women's health conditions and just stating like, this is a fact across the board, and I'm telling you this, and so this is why it's true, and not actually saying, from women's perspective, this is what they say. I think in women's medicine, we have to center women's voices and women's experiences, especially when we consider how long we've been left out of the literature. And I had a really good podcast interview that I'll link to with Dr. Sarah Hill, who we had dinner with. And she made a really good point that even though they decided to start including us in the research, they only include us for about 9 days of our cycle to get us as closely matched to a man. So the people are like, oh, we know about pharmaceuticals. Women are included now. We actually have a huge gap of the luteal phase that we don't understand what is going on with women in terms of drugs, in terms of like their experience a lot of the times. And I would imagine the same is true when it comes to pain.
Of course, yes. We are not the same person 1 week after the other.
Mm-hmm.
Like we can see this in how our bodies, like everything about our bodies is different every week. So I try to explain this to my patients when they go, then they get really frustrated, for example, having their results, if they start working out with their husbands and they see they progress so quickly, but we're different.
Yeah.
So we don't have to do the same diet or the same physical program because women are not little men.
Mm-hmm.
And that's something that really happens a lot of the time when you go to the gym and you try to work out and they don't do any type of exercises. Like it's the same routine, only you have to lift less weight. And I was telling, I think it'll be hard if you have to tell your coach, oh, right now I'm in my luteal phase. Can we go? It'll be hard. It'll be really great if you can have, I don't know, a female like a specialist, and you can adjust your hormones into your workout so you can get the results that you're looking for. Mm-hmm. I think that's something to think about maybe 10 years, but it'll be great if we can try to focus on this. Because sometimes even with diets, like try to, for example, the fasting, like when you have really large periods of fasting, female bodies respond different to male bodies and they do not get the same results. And they also get frustrated by this. But it's different because our fat develops different and their muscles develop different because they have testosterone and all of the hormones that are different. So we are not little men.
Yeah.
There's like this meme of a doctor trying to explain a patient. We have, and he tells that we have studies on mice, chimpanzees, rats, I don't know, like cats, but we never occurred to do this in a female, in a women's body or something like that. I was like, yes, that's totally right. Like, we really need to understand how do women's bodies work in order for us to try to help women.
Yeah. I want to come back to the orgasm conversation. I think that was a really good tangent for us to take. But you have a little bit of a clitoris model.
Yes.
It's actually probably, well, that's a beautiful vulva, I must say.
It's a vulva. So the vulva would be the outer part.
Yeah. Well, and the people that are listening to the podcast, this is a model she's showing me. You should come to YouTube and see it. Okay. I just realized they said, oh, this is a beautiful vulva. And people listening might be like, what is happening right now? But it's like holographic. It's like it actually goes with the whole background.
Yeah, I think it was 3D printed.
Yeah.
So, yeah, and you can see the vaginal hole. I mean, the vagina would be the inside part. So the vulva would be the outside part. And then you can see a little head in here. So you can detach and see the octopus that Dr. Brighten was telling about.
But this isn't an 8 legs, so I got to come up with a better name.
Okay. So this will be the full clitoral body. So you can see there's 4 branches. 2 of them are really wider, and this will be near to your labia majora, not exactly there, but those will be the perineal. So you can have orgasms and you're still stimulating your clitoris while trying to go to the outsider part and also the clitoris, right?
Yeah. No, that is, did you 3D print that yourself?
No. This was a gift from one of my patients.
Man, okay, so my my little preteen has been trying to convince me to get a 3D printer, and seeing that, I'm like, okay.
Maybe you can do really cool stuff, yes.
And he would be like, Mom, you're so weird. I was like, you're absolutely right.
But it's a good thing.
Yes, it definitely is. So when someone is having difficulty achieving an orgasm, maybe there's pain, maybe there's not. Could this be related to nerve dysfunction?
Yes and no. I think we both know that sex, it's so much more and not only about sex. So sometimes when women cannot achieve orgasms, yes, it can be due to a lesion in the pudendal nerve, but that's not the only thing. It's the rarest thing.
Okay.
Also, the hormonal part of it, that's the rarest thing. The psychological part of the orgasm, that's the most frequent thing that women have to address when they are feeling that they cannot achieve orgasm. Because as you were saying, somebody's inside your body. So having this vulnerability into you, it goes a lot of layers before it. So yes, sex is so much more about just penetration, and it's about a lot of things about the partner and about your life and about everything else. And then we have all the other layers. Yes, there's a hormonal layer, there's the pelvic floor layer, and yes, there's the nerve layer. But I think we have to address the the physical or the psychological layer first.
Yeah, I think that's something that's really important to highlight is that there can be such a strong psychological component that also your past experiences can influence your psychological. So if you're someone, maybe you had a really bad yeast infection and then you had pain with sex, that could still linger. There could be a fear there in your mind. So, as a clinician, how do you help people kind of separate that out of like, okay, which came first, the pain or the psychological aspect, and how do we heal both of those?
Yeah, in the consult, they do have to, when they come to my consult, they do have to create the history of the pain. So I ask them to write. There's a questionnaire that I give my patients, and they have to send them 24 hours prior to their consult. I think studying the cases before they come to me, it's easier. So I can now see what we're going through. And also the clinical history. When the patient sits and takes the time to see, okay, what happened first, the pain or the yeast infection, now we can have these clues. And also the symptoms that accompany the pain. Because as we were saying, it's not the same thing to have pain when you're alone than when you're together with somebody. That the experience of the pain is different. And also the position. Sometimes having a seat is really hard for some of the patients. And some of the patients do feel better when they have their legs flexed because of the psoas muscle that we were explaining before. What other symptoms come through or come together with this pain? Like we were explaining about the pudendal nerve, that some of our patients do have this feeling of abnormal object in their anus when they have pudendal compression. So there are a lot of things into the nerves, that really particularities that we have to understand in order for us to understand the pain.
And then I'm also curious, are you looking at any aspects of their nutrition, what their exercise is like when you're evaluating pain?
Yes, because some of when they have contracturated pelvic floor muscles, we think about the life that they go through every day. And if they are, I don't know, physical culturist, or they do have, I don't know, doctors do have a lot of problems trying to empty their bladder sometimes, because we are ordered not to think about it. And then we have a neurogenic bladders. So that's very common. And we also train girls to have neurogenic bladders. I don't know if this happened to you, but my mom, and now I'm giving this to my girl and trying to correct this now that I know of. But whenever you're going out for something, you have to pee right now because we're not going to stop in the highway, right?
I do this to myself sometimes too. But I mean, to be fair, sometimes you go to a public place and there's not going to be a bathroom, or
Yes.
you don't want to use that bathroom, right?
But now you're emptying your bladder without the signal of wanting to empty your bladder. So I tell you, because this happened to me in my residency, they used to tell me that you have to go pee every time you're going to begin a surgery because you don't really know how much time you're going to take. So by God, I swear that whenever somebody told me that it's your turn to wash your hands, I feel that I want to go to pee, even though I go and there's just one drop of pee because my bladder may be empty. But I do have a neurogenic bladder because of this horrible things that we do to ourselves, right?
Yeah.
That we accommodate ourselves in order to progress with this.
Can you define neurogenic bladder?
Neurogenic bladder is having the necessity or the signal of your body telling you that your bladder is full and you need to empty it without really the need to.
And what you're saying is that going to the bathroom just because one's available or you're going to leave the house, so going before you actually get the signal you need to go, is training your body for a neurogenic bladder.
Yes. Sometimes we have patients that do have another type of problems that they have to place a clock, and we ask them to go every few hours because there's no longer any signal for them. But that's because of pain or damage to the nerves due to endometriosis. So it's not always a bad thing. Sometimes it's doctor prescribed. But if you do have these things, go to a urologist, a neurourologist specialist, in order for you to get a proper examination.
How does someone retrain themselves out of a neurogenic bladder? Is that possible?
Yes, but you really need a very good physical therapist.
Okay.
It's going to reconnect you with the real signals of your body. We've spoken with Diana, and she really tries to understand, or for our patients to map themselves and to try to feel every muscle and stuff. So you're trying to reconnect with the true signals of your body.
Yeah, she loves that body mapping, and she'll message me sometimes. She'll just like, thinking about you. Have you been body mapping? And I'm like, how do you know? I've been just like writing my book and being like, body, what's a body? Like, I'm not eating. Like, I have to sit down with like 3 beverages so that I like drink enough fluid so I do get the signal to get up and go to the bathroom and move around. Thank goodness, though, I will say I do wear wearables. And so when I'm hyper focused, my wearable will be like, get up. And I usually get mad at it because I'm like, no, I don't want to be interrupted. But I'm like, yeah, but I also don't want to end up with pelvic pain or a stiff back or, any of the things that come with sitting too much. So we talked about vaginismus. We've talked about vulvodynia, deep dyspareunia. That's pain with deep penetration. This is typically happening in heterosexual couples. What is going on there? What should women be looking for?
Adhesions, adenomyosis, or endometriosis. Adhesions cannot always be caused of endometriosis. You can also have previous surgeries or previous infections like chlamydia, trichomonas, those like really hard infections, like a pelvic infections. Those can really get into like scarring and getting all of the organs together.
What can you do if you have pelvic adhesions that are outside of endometriosis?
Physical therapy can help, and sometimes there are treatments in order for us to remove the bacteria that are around it.
We should definitely remove the bacteria. Yes, fan of that.
And sometimes surgery is indicated, but you have to remember that when you do surgery, other adhesions can come. So the thing that you can do to prevent adhesions in surgery, first, avoid bleeding, or as much as you can avoid bleeding. Treat the tissues. Like one of my teachers used to tell me, like, what's the difference between us and the butcher? Because if you go to the butcher, he's going to dissect the same fascias. He's going to do the same thing that you're doing. And we're like, well, maybe the knife, the sterilization. And he was like, no, it's the way that he treats the tissue. You're not a butcher, so you have to go really through each of the layers. So if you treat the layers with respect, they will advise or heal with respect. So that's one of the things that we really have to go through every one of our surgeries. And also there are like membranes and stuff that you can get in first world countries that do help prevent adhesions. So there are a lot of like Gore-Tex and placental membranes and things that are, some of them are experimental still, but there are a lot of anti-adhesions materials that we can use in surgeries.
So adenomyosis or adenomyosis, let's define what that is. And then I'd love to hear how that's causing pain with deep penetration.
Okay. There's like a layer in your uterus. I'm going to use my model.
I was hoping you pull out your model.
Okay. So this will be if you're looking through a patient like this. So the bladder will be here and this will be the rectum. See, there's like a layer of everything gets together. So that will be the peritoneum. And we can...
Oh, hang on. I think that might be right in front, behind the mic for people.
Okay.
There,
So,
yeah.
Can we, okay. You can see if there's like an inside layer, that would be the endometrium. And then the muscle layer of the uterus would be the myometrium. So there's like an interface between the endometrium and the myometrium. And that layer starts to compromise. So endometrial-like cells start invading the uterus and start changing it. And when they go even bigger, they can even get endometrial-like cyst inside the muscle of the uterus. So that will be adenomyosis. It's endometrial-like cells or endometriosis in the muscle of the uterus. If it's anywhere else in the body, it's called endometriosis. If it's in your uterus, it's called adenomyosis.
And that's basically like a cousin of endometriosis. How often do you see them together?
If you had adenomyosis, there's a 98% chance that you have endometriosis.
And what if you have endometriosis? Should they be looking at your uterus doing transvaginal ultrasound?
Well, if you have endometriosis, yes, it's common. For example, if you have myomas, there's an 85% chance that you do have also adenomyosis. And also, if you have any Mullerian malformations, maybe your uterus is a little shorter or you have like a division between it, or 99% of patients that do have Mullerian abnormalities do have adenomyosis and do have risk for adenomyosis. So the risk is high.
Yeah. And how does this contribute to pain with sex?
A lot.
Yeah.
Okay, so you have something invading the muscle in your uterus. So normally the endometrial or the endometrium do have this like an anticoagulatory, something that makes the blood of your menstruation really loose, red, and it can go very liquid and you can get it outside.
Yeah.
In cases with adenomyosis, the bleeding has to come from the muscle part. It doesn't have anything that prevents coagulation, so it comes in clots. And your muscle, your uterine muscle, has to contract in order to extract all of this. So patients do tell me that they feel the contractions as if they were giving birth in order to take out the blood clots.
Yeah.
So I think that it's not a very pleasant thing.
Yeah.
Sometimes when they have deep penetration, they're going to have, because the uterus in adenomyosis is more enlarged. So they're going to have more pain, and sometimes they even bleed.
Yeah.
The sympathetic tone of the uterus is more contracted. So when they bleed through in patients with adenomyosis, the blood can oxidate itself. So the change of the color of the blood, it's more like chocolate, more like oxide.
Just ruined chocolate for all of us. No, but that's a great description. So I think that's important for women to know that in adenomyosis, we're going to see this darker colored blood, and that's due to oxidation. Because I think when you don't see bright red blood and you're seeing this brownish colored blood, and you just had sex and you're not around your period, you're like, what is that? And so if you're seeing that, see your doctor, because that can be as simple as a transvaginal ultrasound. I say simple, but if you have pelvic pain, having a transvaginal ultrasound can be uncomfortable. I think with the right clinician, It's not, I would say go to an imaging center with a woman or see a female practitioner, because they definitely understand things a lot better. They can have you contract and tighten, and then release, and that can help relax the muscles. There's different things that they can do. So I say this so that if you are someone who's like, well, I have, vaginismus, therefore I can't have this ultrasound, you may still be able to, but you have to find the right person.
And also, that's not the only cause of having a darker color in your, because if you have low progesterone, you're going to have a darker color in your blood.
Yeah.
So in your period. So that's not the only cause. It's one of the causes.
Yeah.
And also, patients with adenomyosis, because of the sympathetic tone, they bleed in pulses. They bleed a little bit, then it stops. Then they bleed a little bit more, and then it stops. That's also a sign for adenomyosis. That's not the only sign. We're not saying that if you have this, you have adenomyosis. We're saying it all contributes to the diagnosis.
Yeah. And we know, for women listening, I talked about in my book, and I said this before, like you may have a 5-day period, and then you have that day where you're like, is my period gone? And the next day there's a little bit more. That can be really common and normal. What you're saying is based on the contraction. It's like, I bleed, then I don't. I bleed, then I don't. And it's like a teenager driving a car, like a stick shift. You're like, just make it smooth. Let's go. Let's be done with this. So with adenomyosis, the other thing that comes up as we're talking about this is the position of the uterus, and that changes throughout our menstrual cycle. Can you talk about that? Because that can, I think about there's certain positions when you're having sex where there's deeper penetration and you can have more pain. Like, women will be like, I could do what people call doggy style. I don't know if they call that here. Okay. That's fine. Like, if I'm around ovulation, but like before my period, I'm in so much pain. So can you talk about what is changing anatomically?
You have your round ligaments that your uterus is attached to them. And when you have, for example, a disease from collagenous like Ehlers-Danlos, our patients can even have even more movement in the uterus. Sometimes they even have, when they have retroverted uterus, they do feel more pain. And it can cause even congestive pelvic syndrome. There is a practice that we can shorten the round ligaments so the pain will diminish. But also because of the adenomyosis, the uterus is heavier. So sometimes the uterus is supposed to be looking to the bladder in the anterior part. And sometimes because of the weight of the uterus, yes,
right?
So yeah, so the uterus will be here. So if you have the uterus seeing your bladder here, so that will be the anterior version of your uterus. So that will be a normal thing. So sometimes because of the weight of the adenomyosis, the uterus goes backwards and it's attached or more close to the rectum. So they do feel pain during intercourse, not only because of the localization of the uterus, but also because the uterus is poking the rectum. So that won't be very pleasurable.
Yeah.
Yes.
So I actually did an Instagram story right before you got here. You'll probably see it where I was talking about wearing this outfit today. And I have adenomyosis and I lost some ligaments during my surgery. And how, I'm going to probably get my period tomorrow or the next day. And how like my belly's sticking out here because my uterus is bigger. Anyhow, I did the story to kind of normalize this because I think there's this idea that we're supposed to have 12-year-old bodies our entire life and that like your lower belly should always be flat and like, and women don't, I mean, God, Photoshop was bad enough. And now we have AI cover models. Like now, like you modified women and now you're not even using real women and you're telling us this is the beauty standard. And I'm like, forget that. Like, I'm going to show like the weird things that happen to my body and like talk about it and normalize it because, I have boys and I also don't want them to live in a world where like we have these like fantasies that we can never achieve or look up to. But people who have this condition, like I can feel that my uterus is getting heavier. Like I can feel it when I'm working out. It's not that extreme but thanks Deanna for all the body scans that I'm like in tune with it. And I'm like, yeah, as I'm working out, I'm like, oh, I can feel that there. Okay. My period's going to come. But for some women, it can be a lot more extreme. So I want to talk about what are the options? So if you have adenomyosis, that's causing pain with sex. What are your options?
It depends on the type of adenomyosis. There are 3 types of adenomyosis. You can have adenomyosis mixed with myomas.
Mm-hmm.
You can have focal adenomyosis. That's like only one part of your uterus having adenomyosis. And you can also have diffuse adenomyosis. That'll be like the worst type.
That's me. Thanks for saying that.
Because there are not a lot of things that we can offer these ladies. When you have adenomyomas, we can remove the myoma and it'll come out with the adenomyosis. If you have focal adenomyosis, we can remove the part of your uterus that it's with the disease. Where in patients that do have diffuse adenomyosis, especially the ones that are in early stages, that it's only in this area between the endometrium and the myometrium, you have to remove the whole uterus in order to get the full like eradication of the disease.
Mm-hmm.
Sometimes you can have diffuse adenomyosis in the muscle layer. And now with the experience in the robot surgeries that you have better cameras, you can start defining the difference between the tissue layers, and you can find adenomyosis in between the muscle layer, and you can try to remove them. But to fully remove it, it's really hard experience, especially in diffuse adenomyosis.
Yeah. I grew up in California. We have this cut of meat called tri-tip that everybody barbecues. And so I tell people because people are like, why don't you just have them excise, like take out the tissue that has the adenomyosis? And I explain, if you look at a marbled piece of meat and you see the fat chunks that are in it, imagine if you went and you dissected out every piece of fat chunk, what would you have left? You would have this weird, no longer holding a structure piece of meat. That's exactly what would happen to my uterus. So, for people listening, so nobody likes to hear hysterectomy, although some people do. Some people are like, I'm done with this uterus, right? Because it's so big, it's so boggy, it's so painful. The periods are, they're not these like 3 to 5 day periods. These are like 10, 12 days of like, when am I going to stop bleeding? Because it's just so ineffective in its contractions. But one thing that we can use is bioidentical progesterone, and using that during the second half of the cycle. I don't typically, if you're somebody who's under 35, I like to think more of like vitamin C, vitamin B6, Vitex, like what can we do to get your progesterone levels up, and then also support estrogen detoxification. So helping you remove the estrogen you don't need. Once you get over 35, and especially in your 40s, that's when I'm like, it's a good idea that if you're still ovulating half the month, to take an oral micronized progesterone. And a lot of people, that will help you sleep. If that's not true for you, I have an episode on progesterone intolerance that I will link to so you can watch it. Or even doing vaginal, which vaginal might even be better. It's just women just hate doing it because it's messy. But it may even be better because we know it affects the uterus because it's being placed very in close proximity. So with that, that's not going to be a cure for adenomyosis. That's going to be management so that we're not getting the overstimulation of estrogen, which is really common in our environment because 1, most people don't eat enough fiber. 2, xenoestrogens are everywhere. And 3, some people have a good time. They drink alcohol or they're not always like adhering to things. So we can have that progesterone buffer so that it opposes estrogen within the uterus. But if somebody is like, my primary complaint is just pain with sex, would you recommend a hysterectomy for that? Okay.
Of course, no, we do recommend hysterectomies in patients that do not have a quality of life because of their uterus.
Mm-hmm.
And they have tried everything else before.
Yeah.
I think there's like I don't know, like a dual phase that comes with losing an organ that I've seen in the faces of my patients.
Mm-hmm.
Some of them are ready to lose one part of themselves. Some of them are not. And we are not in order to force them into it. It's one solution, but it's not the only solution.
Yeah.
And removing organs just because, it's not the way to go. So no, pain during intercourse, you have a lot of other things like physical therapy, like hormonal treatments that can help you with the pain during intercourse complain. But if you do have an enlarged uterus that it's causing to bleed every month, that it's causing you that have clots, that it's causing you anemia, that we are not even able to control all of the bleeding that you do have, and that your period is determining your life.
Yeah.
That you cannot go outside, or you cannot go and play with your kids because you feel very fatigued, or that you cannot go to the beach because you don't feel comfortable. Some of these things that women do experience with having adenomyosis, that's the way I think uterus, it's not supposed to hold you back. So if it's done and you have had your kids, if you had your kids, if you wanted them, some of our patients don't even want kids. So that's their decision. But I think that there's a whole lot of things about the hysterectomy that needs to be addressed before taking this decision.
There's been speculation and a call for more research about the potential of the uterus having an interaction with the immune system. Have you seen any research around that?
Not something that we can have like a randomized control trial that we can say that now this is something that we can really go back into it. But I think there's something there, yes.
Yeah.
Because some of the autoimmune diseases, my friends that are specialists in this told me that if they get a hysterectomy before a certain age, especially before the age of 40, patients with autoimmune diseases get worse.
Interesting.
So I don't know if there's this is not a randomized control trial. This is just an observation in a very small group of patients in Mexico. But yes, something like...
I mean, and this is the thing that's so hard to do, is that we know the randomized control trial is the gold standard. And, you know, Dr. Sarah Hill made such a good point during our podcast episode. And I wish that we had talked about this when we were at dinner, because she had said to me, the way we have designed science, the entire design model of science, is for men. And we've never stood back and said, how can we design it so we have a gold standard for women? Because we can't have we can't always do the same thing. Women get pregnant, women could get pregnant, and there's just so many other variables. And it had never occurred to me that everything that, when you talk about things and people criticize and they're like, well, you know, that's correlation and that's anecdotal. And it's like, but have we ever paused and stood back and thought about, did we actually even design science from its inception to serve women? Or maybe do we need to redesign it differently so that we can have good data, right? Because, I mean, I learned so much on this podcast from talking to experts. And I think we learn so much from listening to our patients, right? I think that, you know, to your point, that observation makes sense, because we know that there's also a risk that when you have a hysterectomy that you may go into menopause. So depending on where, and I'm not a surgeon, but this is what I've read, depending on where cuts are made, that can impact the blood flow to the ovaries. And if the ovaries quit, now we're in early menopause. And we know the transition of losing your estrogen puts you at high risk for developing an autoimmune disease.
So everything is linked.
Yeah. So what risks should women know about hysterectomy, since we're on that conversation? Because I see a lot of doctors that are pretty flippant about, like, well, if you've had your kids, just take your uterus, like you don't need it. I one time had a patient, she got her chart notes from her other doctor. I was so livid. I know it's not professional, gets so angry, but he put in there that he recommended, she was like 28, that she have a hysterectomy because she was having pain with sex, with deep penetration. And he had said, like, I'm recommending hysterectomy so that she can accommodate her husband, like in the bedroom. I was astounded by this. And I'm like, why? And she's like, well, because he said I have my kids and I don't really need my uterus at all. I'm like, this is a major surgery to have your uterus out. And like, did you talk to you about physical therapy? No. I'm like, let's start there. But for women who are considering a hysterectomy, let's talk about who you should look for in a doctor and what you should know about recovering from that and what the potential issues that can arise.
So you have to do your research and see the type of surgery that your doctor performs. Here in Mexico, we have doctors that don't perform minimally invasive surgeries. Mm-hmm. So that'll be the first thing to know. If you do have somebody that gives you the option of having less scarring in your abdominal wall, it'll be a quicker comeback into life. But you do have a vaginal scar that we have to suture in your vagina. So these types of injuries do take 1 month to heal and up to 2 months in order to have sexual intercourse again.
So you're talking about doing a hysterectomy going through the vagina to remove the uterus?
You can, in any hysterectomy, you do the vaginal cuff to remove the uterus.
Okay,
So
okay.
if it's a laparoscopic, for example, we remove the uterus through the vagina. We do the vaginal cuff, we remove the uterus, and then we suture the vagina.
Yeah.
Even if
I
it's
just want to
an
make sure that
surgery.
it's clear what we're talking
of
about.
course, yes.
Because I think, because we talked about C-section before, and I think that, it's important that we differentiate where incisions are being made.
Yes.
Because if this is the first time someone's hearing this, like if you've had a hysterectomy, you're like, I know the drill. If this is the first time you're hearing it, you might be like, wait, they're not going through your belly?
If you have a minimally invasive hysterectomy, no, your uterus will be removed through your vagina.
Yeah.
So that's how we can accomplish having lesions of 5 millimeters, removing an organ that it's so much bigger than that. And also about the technique and about the experience of your doctor. How many surgeries has he done in this year? You can ask them that. We, as surgeons, we have to get certified by some associations, and they do ask us for our statistics. So you have an idea of how many surgeries you perform a month. And then you can ask them about the complications. The uterus, it's in between everything. So you can have complications with your bladder, with your uterus, with the rectum. So those are the things that you have to talk about with your surgeon before the surgery, no afterwards.
Yeah.
So after the surgery, after 1 month, you can go into physical therapy. There's a lot of things that they used to think, or when I was in the residency, they used to tell us that we have to attach the vaginal cuff into the uterosacral ligaments. There's not such a thing as a uterosacral ligament. There's not a ligament there. The peritoneum, that was like the white thing that we saw in the beginning. Imagine that you can cover everything with plastic, that you can fold everything like a self-adherent plastic, and you cover all of the viscera in your pelvis. So with this, that's the peritoneum. And sometimes this plastic can get into a little wrinkles. So you have 2 wrinkles in your peritoneum in the backside of your uterus. Those will be the uterosacral ligament. Those are foldings into the endophagia. So that's the backside. And it doesn't have any muscle like the round ligaments. So it's just a lot of connective tissue, and it's part of an even bigger fascia. So they used to tell us that you have to adhere the vaginal cuff into this in order for them to not have any prolapses. But the thing that we didn't used to know is that the inferior hypogastric plexus, the one that controls how you empty your bladder, how you relax your muscles in order to have sexual intercourse, or how you poop, those nerves are a centimeter and a half or half a centimeter away from those ligaments.
Oh, okay.
So if you do have this procedure, some of our patients, after a little bit, are not able to empty their bladder because we are damaging the nerves. So that's a practice that should be avoided. Also, another practice that should be avoided is cutting or burning nerves in order to forget about the pain. This is a procedure that is still being made in Mexico. It's called Luna because it's the ablation of the uterosacral ligaments. So if you burn a nerve, if you cut a nerve, you do not diminish the pain. You only make it untreatable, and you also will have the other side effects. The emptying of the bladder being really messed up, not being able to have sexual intercourse, and not being able to poop. So that's a lot of problems for a lot of nerves being burned.
Yeah. Do you ever do like anesthetic injections into nerves?
Yes. Yes, we do nerve blockages. I don't like the one, I see sometimes in the United States, they do this and they tap, and whenever the patient feels pain, they block that sign. I don't like this because I don't think that there's a diagnosis behind it. You have to find the nerve, block the nerve, and if the patient feels a lot of relief, even it depends on where you find the study. They used to say that if it's a 50% better of the pain, that's the nerve. Now we do know that the pain has to go away in order for you to make the proper diagnosis. So if you do find the nerve that is causing the pain and you block it, that's a diagnostic and also therapeutic way. So if it's just a sensory nerve, you can add Botox to the nerve and you're going to feel the remove of the pain for a longer period of time.
Okay. A lot of people are afraid of Botox because they're like, it's a toxin. Shouldn't I not be putting it into my body? Explain how Botox can be used therapeutically when you're having pelvic pain or pain with sex.
Because Botox can inhibit the signal. But when you have Botox on your pelvic floor, you have to be really careful because Botox prevents muscular contraction.
Yes.
So if you have a contracture or like a contracture or something, it may help. But for example, if you have a prolapse or problems with your pelvic floor stability and you add Botox, your bladder is going to go outside of your body because nothing is going to hold it. So that's why it can even worsen patients with prolapse.
Yeah.
So you really have to go with somebody that knows what Botox does to your body and your pelvic floor muscles, and it's not indicated in all of our patients.
And when you say prolapse, can you define that for people? Because I don't think everyone knows what that is.
When your organs are going outside of your body,
Yeah,
through your
that is really
vagina,
simple.
like it's like you're birthing your bladder, your uterus, or your rectum.
And so for women listening, you'll feel a bulge in your vaginal wall. So if it's the belly button side of your body, that's bladder side. If it's the tailbone side of your body, that's the rectum. But even the uterus can start trying to make an escape, depending on the pelvic floor and your history as well. So how effective is you doing a nerve block or Botox for helping pelvic pain? Like, is one better than the other?
No, the block can only help you with a little bit of time. So sometimes we accompany it with Botox, and sometimes they give a radio frequency therapy to the nerve. It depends on every nerve. It depends on every patient. So it's not indicated for all of them.
For women who have had a hysterectomy, they didn't have pain with sex, but now they are, what could be going on?
A lot of things.
You're like, once again, buckle up.
Yeah, it's like everything changes right now, and you're feeling for the first time things that didn't used to belong there. We used to think about the pelvis like a pea pod. So you have the bladder, you have the uterus.
What's that word?
Like a pea pod. Like
a pea pod.
Yeah.
Okay.
You have like a little three little piece inside of your pod. So you have your bladder, you have your uterus, and you have your rectum. So whenever this little piece, like stretching one of their elbows or something, the other two are going to start moving. So if you remove one of these, the other two are going to have so much space. So they're going to move even more. So sometimes if you have pain during intercourse after a hysterectomy, you have to see where is the pain again, because if it's in the outer side of your pelvic floor, I mean, in your vulva or in your, like in the promontory, well, in the inside or where the penetration is beginning, that'll be one causes. It's more frequent to have like lacerations or infections. If it's in the middle part, it's more frequent to have pelvic muscles contracturated. But if it's in the vaginal cuff, it's really rare because there are no nerves anymore in the terminal branch. So they used to feel, or when I've talked with my patients with vaginal cuffs, they tell me that they don't feel anything when they're hitting the bottom.
Okay. And so if women are experiencing this, who's like the first provider that they should see?
Hopefully a GYN that knows about pain, because sometimes sutures can get into the way and they feel pain. Sometimes there are residue material. Sometimes they didn't remove the cervix. There are a lot of things that need to be like checked out before you can address the pain whilst having intercourse in like a deep penetration after hysterectomy.
But it can be addressed. It's not just hopeless.
No, it can be addressed. Yes, every pain can be addressed.
Yeah, I want to ask that question because I feel like sometimes when women go to their provider, and it's so much effort and energy just to go to a doctor, and then they get hit with like this is just the way it is, like this is your new reality, that can feel discouraging. And I think it's really hope inspiring for women to hear from such an experienced clinician as yourself say, there is always hope. There's always something that we can do with that. For women who are experiencing pelvic pain in general or having pain with sex, should they talk to their gynecologist first? Should they see a physical therapist first? Like, what's kind of the algorithm there of who they should try to see? Because the other thing I get concerned about is that there's a lot of gynecologists who don't even know physical therapists are a thing.
Yes.
So they don't refer to that. So maybe for somebody listening, like, what are the steps to go through to help find the cause of why you're having pain with sex, but also find resolution?
You have to first find it.
Mm-hmm.
So first find the place where it's hurt, if you have the pain. Then allow us to map it, and then we try to fix it. But about the doctor, you have to go to somebody that do have physical or pelvic pain in some kind of background.
Mm-hmm.
Because if you don't, you may get the same answers that you're going to get every time. So yes, do your research and find somebody that do has pelvic pain background in any other, like any studies, and or do care about pelvic pain in women.
Mm-hmm. We have touched on throughout this episode on endometriosis. I want to talk specifically pain with sex when it comes to endometriosis. What do you most commonly see?
Because of the adhesions. Because endometriosis, we know that can get everything stuck together like a frozen pelvis.
Yeah.
So the most common ones are because of we have like mapped like the macro pattern of the distribution of endometriosis. And this is one of the reasons that we do the gel MRI, that do have gel in your vagina and in your rectum. The number one place that endometriosis appear is the rectovaginal Pelvic, like the space.
That was me right there.
So that's the number one.
Yeah.
The number two will be the uterosacral ligaments. So if you have everything in a grayscale and you have a layer in between the rectum and the vagina, and you add two whites into a black, you're going to make the black even more noticeable. So that's one of the reasons that we do the gel MRI. So yes, this is one of the spaces that it's more commonly affected by endometriosis. And we have to remember that endometriosis, it's not, the amount of pain doesn't correlate with the amount of endo.
Yeah.
We have had patients that do not have any pain and have nodules in their bladder, in their rectum, in everywhere. And they're like, I don't have any pain. I've never had any pain in my menstrual cycle. I've never had any pain in my life. I'm like, how do you live? Like, and we have had patients that only have peritoneal disease, that I think it's the worst because it's the one that affects our patients more. And even it's like a 4 millimeter lesion, they do feel the worst pain, and it changes their life, like every dynamic that they do have. Some of my patients tell me that they have to organize all of their work in 3 weeks because they know that 1 week they're not going to be able to work. So they do still have all of the things that they have to manage throughout the month, but they have just only 3 weeks in order to do it.
Yeah.
So I think that's, I don't know. And they have to alter the way that they have vacations. They have to alter the social gatherings. Everything goes around your disease. That's the thing that I think it's very horrible about this.
For people who are not familiar with peritoneal endometriosis, can you describe that for us?
It's like the outside layer of every viscera. The peritoneum, it's like an outside layer that covers everything.
So this is like the saran wrap you were talking about, the
Yes.
plastic wrap.
The plastic wrapping.
And with that, you're talking about, so people having very small lesions, but within that causing some of the most pronounced pain compared to others. You know, it's interesting because, so you talked about gel MRI, you talked about getting imaging. I know in your clinic you do imaging before you ever do surgery. I will bring up talking about stages. And anytime I'm talking with surgeons, they're like, we hate stages. They're stupid. Like, why are you guys still talking about it? And I'm like, stages are for patients. Stages are for patients, not for clinicians, because we'll talk about, and it's just something that, like, you know, I tried to talk to people about my Enzian score. People are like, what? Okay, Enzian score is way more descriptive, way more helpful. We have a whole episode on that I'll link to. But when it comes to stages, I feel like patients, they like to use that language because it's usually it took me 15 years and then it was stage 4, like, and to just demonstrate like how big of a deal like this disease was. But as you're saying, and I think this is really important just to underline for people, is that it could be something that is, you just have a couple of lesions, but it's causing the worst pain in your life. You could be completely infiltrated, have adhesions everywhere, and you're living your life just fine. And I think we have to validate that just because you're not stage 4 doesn't mean it wasn't hell that you were living through.
Yes, of course. And it doesn't mean that you don't need a surgery. It means that we may try to fix the symptoms with other things. Like we try to go through physical therapy, get a proper nutrition in order to diminish the inflammation. This can do help peritoneal lesions, but it's really important that some of our patients do still live in pain, and we're not going to tell you, no, I won't do a surgery on you if there's just a 4 millimeter lesions. We have to really trust our patients, because some of the peritoneal lesions get into pockets, and this can adhere to very deep parts of their pelvis, even into the nerves, and they cause really inhabilitating pain. So it's really hard.
Is that why peritoneal lesions, you think, cause so much pain? Or is there something else?
It's inflammation. And it's like having, I explain my patients that it's like having a candle that it irradiates like heat. So if you have a nerve, it's like a wire that do have like a plastic protection. And if you get the candle very near to it because of the inflammation that it's burning everything, you're going to have the outside layer of your nerve getting like diminished because it's the heat, it's affecting it.
Yeah.
So
that sounds awful. And I think it's a great description for endometriosis, because I'm like,
inflammation.
Yes.
So
yeah.
You have to address the inflammation.
When it comes to surgery for endometriosis, though, oftentimes you see people online are very divided, and you'll see in the endometriosis community, women are like, everyone has to have excision surgery. And then other people are like, no, you can do it all, just like nutrition and lifestyle. What are your thoughts about surgery? Is this something that everyone should consider, at least be evaluated for? What do you think?
Everybody needs a diagnosis. That's the first part. When they tell me like, what do I need? You need a proper diagnosis. They write me sometimes and I'm like, oh, this is the thing that they told me. No, we need to do a proper diagnosis. Once we have the diagnosis, we can make decisions. All of our patients need nutrition. Most of our patients need physical therapy. That's like the basis of our treatment. It's a multidisciplinary treatment because it's a systemic inflammation, chronic disease. So the whole body is participating into getting rid of those cells that doesn't recognize. So it's like having a flu that doesn't end. The inflammation doesn't go away because the cells are still there. So if you don't address this, it doesn't matter what you can do the best surgery that you can, but you're going to still have inflammation. So you need to address the basics. And then there's like statistics that say that from 10 to 20% of the patients really need a surgery. Most of them can get by without symptoms, having just some changes in their life, in their everyday life, like diet and exercise and stuff. But the thing that we really need to understand is that if you do not address the inflammation, the symptoms won't go away. Yeah. And even if the symptoms go away, the disease will still be there. So when you don't take care of yourself, the symptoms will come back.
Yeah. So people that are not familiar with my story, I had incredibly painful periods. Like first 3 years of menstruating was absolute hell. Throwing up all the time, more than 7 days of bleeding, missing school. I got put on the pill, did that for 10 years. When I came off, hell returned. Actually, I had all these ruptured ovarian cysts and I had all kinds of problems while I was on the pill that I was like, that was endometriosis this whole time. So things didn't get better for me. But when I came off, it really got bad. And I went in with nutrition and lifestyle, was able to have no symptoms. And I was shocked when I got my MRI, how much endometriosis I had. And I was like, how am I not in pain? How am I not? And it was because I was managing it so well. And for people listening, I also have Hashimoto's and psoriasis. So like I have to be really like very dialed into my diet and my lifestyle so that I can function. But with all of that, I think, people are always like, why did you get the surgery? Well, I was on a fertility journey. We thought this was going to be the thing that was going to help. That ended tragically. I'm not going to get into all of that. But what I want people to understand, because people were like, oh, well, then you had the surgery. You can just live your life now, right? And I'm like, no, because when you live with endometriosis for 29, it's been there probably since, I was formed as a little organism, but 29 years of menstruating, going through that long of your life, there are alterations that are going to happen. Your immune system is already heightened to go into inflammation. But, I also think about the research, and I really dislike how many people took the research on the gut microbiome. And they're like, we know the cause of endometriosis. It's alterations in the gut microbiome. And I'm like, what does that have to do with lesions being in someone's eye? Tell me how these gut bugs made a lesion get into someone's skin or end up in their peritoneum. Makes zero sense. I actually think that having the endometriosis and the dysfunction that's happening with the inflammation, the hormones, that starts to lead to alterations in gut microbiome, but also the way you start eating, right? Because some women can't even eat. So we see diet changes. Anyhow, I like getting research that's there's differences in the gut, but to be that's the cause of endometriosis, I think is pretty silly. I took a little more of a side tangent there than I had planned. But for women who are listening right now, who are struggling with pain with sex, we have gone over the different areas that, what could be, so the different areas that can present, what can be contributing to it. What is something that we have missed in this conversation that I have not brought up and pointed out?
I think only about the treatments.
Okay.
Okay. Sometimes there's vaginal treatments that we can perform. I think getting back in touch with your body, I think will be the best thing and to do the proper or to have the proper doctors to perform the proper physical exams. I think that'll be a thing to really have in consideration if you're thinking about getting a consult. And then for the therapy, it's not about numbing the pain, it's about treating the pain.
Okay.
So when you hear your doctor saying, oh, you have pain, get these painkillers. That's not the thing. If you have pain, let me look for the way that the pain is traveling through your nerves, and let me see the experience of the pain that you're having, and then get a solution together. That'll be the thing.
Are there any new treatments that are coming up in the research, in clinical practice that you're most excited about?
Not exactly new, but I think some of the vaginal therapy that doesn't go into the bloodstream can help. Some of our patients have gone through clinical menopause because they have gone through a lot of injections that suppress their estrogens.
Mm-hmm.
We have American girls that are in their 20s with osteoporosis because of all of the injections that they did have. And they do have pain having intercourse, and they deny the estrogen, the vaginal estrogen. So endometriosis patients are not if they do prescribe estrogen for their vagina, they do have less systemic function if you have a vaginal estrogen. And it can help so much to those patients that went under all of those years without estrogen or with estrogen suppression or with chemical menopauses that I really hate. But sometimes those type of patients can
I hate them too.
So, and then when they tell them that, no, you cannot have estrogen in your vagina because your endo will come back. Okay, you do have to understand the way that it's absorbed and the dosages that you need to use, but sometimes it can help so much more.
I did Lupron for 2 months. I got vaginal estrogen. I was like, this is not even a thing. And my doctor, he had that concern. And, I just said respectfully, this is my area of expertise. And I'm doing vaginal estrogen because I don't need a UTI. I don't need a yeast infection going through this. And I also don't need pain with sex. I appreciate you bringing this up in the context of women outside of menopause, because we're talking, it's a very interesting thing because we call menopause hormone therapy, MHT, But, a colleague of mine brought up it's not very inclusive because we're actually using what is considered menopause hormone therapy in younger women as well, those who have primary ovarian insufficiency, those who are put on drugs like Lupron. Even the progestogens, the progestin drugs that are used for endometriosis, women can start to have issues with their vulva changing, having vaginal dryness. And so I appreciate you bringing that up because there's going to be a 20-something somewhere who's going to be like, oh my God, like I just got given Lupron and it's like sandpaper down there. Like it's so dry. And so I really appreciate that. Other things that I will say that you can also do over the counter. It's not as good as vaginal estrogen, but vitamin E. There's places that do vitamin E suppositories. You can get them compounded. You can be just really cheap, like I would be, and just go get, 400 IU capsule, poke a hole in the top of it and insert it into your vagina. That's seriously the cheapest way to go with it. But the vitamin E can help plump the tissue and that can help a bit with dryness. It will break down a condom though. Just for everyone to know, anything oil-based will destroy a condom, and that can be problematic. And if people are like, but I can't get pregnant, we talked about pelvic inflammatory disease. You can still get gonorrhea and chlamydia, friends. So with vaginal estrogen, is this something that you are using in your clinic with patients who have pelvic pain? Talk to us about it.
It because some of the dyspareunia causes, it's a hormonal cause. Especially, we see it more commonly, yes, in postmenopausal women, but also in premenopausal women that are still bleeding, but there are in many perimenopausal women. Sometimes they do need vaginal estrogen, and it's not a bad thing. So you only need to think about the way that this can be absorbed and the way that you have to counteract in case the patient do have a uterus. But it's not counterindicated, and the absorption it's less than if you are taking by orally. So it can be something that you can do, and it can change the life of the patient if they have, again, a vagina that it has a mucous layer that can get into it and do have, again, probiotics and good bugs in there.
Yeah. I always like to talk about estrogen being our little farmer that helps us cultivate the lactobacilli crop. And it's something, so for women who don't know, estrogen stimulates the cells that produce glycogen, which is a sugar that the lactobacilli feed on. Lactobacillus acidophilus, these lactobacilli species, they create acid, makes the pH of the vagina low, and that keeps the yeast that does live there in check. So really, really important for the vaginal microbiome. Interestingly enough, I've presented on this in a couple of conferences, and I'm presenting again next month on this, on how losing estrogen changes not just our vaginal microbiome, but our gut microbiome in a very serious way. And so I think it's something that a lot of times people think about estrogen and they think about like, oh, it's just about feeling good. I mean, it's about having great bones. But when we talk about vaginal estrogen, that's also about protecting your vaginal microbiome, which is super, super essential. You talked about oral estrogen. Something I find interesting in Mexico is that doctors aren't using transdermal patches.
Yes, we do.
You do? Where do you get them? Because they're not at San Pablo.
I can get you the brands that
okay.
and it's easier by gel, but I don't like the gel because they do sometimes pump twice or pump. I don't know that amount of grammage that they do have. Yes, and you can have there's like patches of estrogen and progesterone also.
Oh, interesting. Yeah, because what I have seen, I've had a lot of people talk to me about it, and there's the gels, there's creams, and then there's the sprays, and I'm like, I just don't like these delivery forms as much because I can't know if you're getting the exact right dose. Like it's a lot to like recommend or to rely on somebody to eyeball things. And sometimes the creams, the dosage is like, that's higher than someone needs. And to cut it in half is like so tiny. So that's good to know. In endometriosis patients, they're often told you just need to get to menopause and then not have hormones, and then you're going to be fine. What's the truth there?
The endometriosis lesions produce its own estrogen. I have one case that I'm trying to publish because it was so many years ago, so I don't have everything in order to publish it. But there was a referral of a postmenopausal woman. She was in her 50s and have stopped the bleeding for like more than 5 years. So she had tachycardia, and she went to the cardiologist, and the cardiologist referred to me because it was a postmenopausal syndrome. So I was like, okay. And I performed an ultrasound, and there was like a tumor in her ovary. That was an endometrium.
Oh.
So when we performed the excision surgery she had her FSH normal and her estrogens level not normal. So we were like, what is happening to her pituitary? So something is wrong there, right?
Yeah.
So we found out that the levels of estrogen that the endometrioma was producing she didn't need to produce the FSH because it was regulating. So I think there's not so much information there because the estrogen that the endometriosis produces doesn't get into the bloodstream labs usually. And in this case, she had like estrogens, like if she was a 15-year-old, but postmenopausal.
Yeah.
So it was really weird.
Yeah.
And after we performed the excision surgery, her estrogen levels went down. So I was like, this was self-regulating her. So that's why she didn't have any perimenopausal or postmenopausal syndromes.
Yeah.
Her endometriosis was helping her. But where I'm going to go with all of this is that if you have a rectal nodule because of endometriosis and you go through menopause, you're going to still have your rectal nodule. The thing that does go or diminishes is the amount of estrogen. So sometimes, for example, in patients with adenomyosis, as they are not longer bleeding, they do feel a relief of the symptoms, but the disease is still there.
With that patient, how was her endometrial lining? I'm just curious because if she had all that estrogen but no progesterone.
Yeah, it wasn't enlarged. It was really weird.
Interesting.
It was a really, really weird case. That's why I wanted to publish. But it was before we have like where I used to work, there are not like very records. Like it was all on paper and the filed, and you have it's a long story. Yes.
Well,
yeah. Hopefully, we'll be able to publish.
I know. Yes. I'm like, when you do, share that with us. We'll share it with everybody. My last question about treatments: topical lidocaine often gets prescribed when a woman is having pain at the introitus, the opening of the vagina. What are your thoughts about that? I mean, I can kind of guess where you're going to go, but
okay. So you can have like when patients have vaginismus or they have memories of pain, because sometimes pain is the memorization of the pain. So when they have had experiences with sexual intercourse that are painful, they remember this experience and they start feeling pain even before the experience begins. So sometimes the vaginal gel that has like a water-based gel and does have lidocaine can help them to improve the experience, but it won't do anything about the real cause of the pain unless they address it.
Okay.
So it numbs the symptom, but it doesn't give you any real relief.
Well, thank you so much for taking the time.
Thank you so much for having me.
Yeah,
yes,
thanks for bringing all your models.
Hi, thank you.
Thank you so much for joining the conversation. If you could like, subscribe, or leave a review, it helps me so much in getting this information out to everyone who needs it. If you enjoyed this conversation, then I definitely want you to check out this.